Well, thank you. And first of all, I'd like to thank the Academy for giving me the opportunity to share some of my experiences over the last 4 years. The body of information that I'm going to share with you today really comes out of treating north of 125 cases of either screw fractures or abutment and screw fracture cases being referred into the practice for the most part. So we're going to separate the objectives here this morning into three parts. One, I'm going to show you a case, first of all, just to show you what can go wrong when the appropriate armamentarium and the appropriate visualization isn't used. And then I'm going to go into a simple screw classification system that's come out of my head after treating these cases, just to help delineate the easy ones from the hard ones and to try to keep out of trouble. And then the third area, we have to come down to the idea of what to use in tooling and recognize that the necessary tooling might not be out there, but I need to give you a way to evaluate that tooling. So let's delve into the first case, and I called it Robert's wreck. Poor Robert had a unfortunate experience. He's in the LA area. They were about to seat a zirconia abutment and fractured the screw going into the case. And so I think panic ensued. I'll put the exploded version up here. And as pursuant to the first lecture we heard, that performance went down as anxiety went up. And he called the lab technician, and somehow he got in his hands a fragment fork, which is really a reverse cutting end mill, and probably put it in a slow-speed handpiece and went after trying to get this screw out without a lot of experience. And unfortunately, what occurred was an implant. This is a 4.1 implant with some altered interface issues and screw issues. Now, the image that you see on the right was taken through a microscope that I used for a couple years across the street in an endodontic office, and it had a video camera on it, and it would frame capture the video. So the image isn't quite as crisp as I'd like to see, and you'll see better ones as we progress on. But in this first this slide, this expanded view almost to pixelation, you can see on the lower right at about 5 o'clock there's one circle, and then up in the 10 o'clock area you can see this enlarged circle, this crop circle, and I'll annotate it for you so you can really recognize what's going on here. The circle, the yellow circle that you see is really center line of the implant. This photograph was taken a little off axis so I could get both of the damage and the screw in place at the same time. And so yellow is concentric on a metric 1.6 screw, retaining screw at the end. That's what's left in here. The crop circle on the left-hand side is denoted by the red circle, was the damage created by this fragment fork as I brought in here. This happened to be a metric 1.4 fragment fork that was utilized in this case. And so you can see that there was not a lot of visualization going on here, which is one real big problem in removing these screws. And the other issue was even if he had been able to see what was going on, the problem is that he had the wrong tool, and it was not guided. So if you understand, you would think initially that you could use a metric 1.4 fragment fork on a metric 1.6 screw, and you would be safe. But in reality, the screw hole that's used to pre-drill a metric 1.6 is only a metric 1.25 drill, so the difference is just thread. So if you went after a metric 1.6 screw with a 1.4 frag fork, you would be destined to start taking out implant threads at the same time. So under a pure mechanical point, this was a problem. So maybe a little bit easier to see was I took impressions along the way of the site. This first image is just an impression of an analog, and then you can see the impression of the implant after the screw fragment was taken out. Really, with guidance and with the proper tooling, the screw was easily removed from this implant. But unfortunately, there's quite a bit of damage that was created. So much that in this particular case, you really couldn't use stock components in this re-restoration because there would be no thread to gain preload and have stability over the term of the restoration. So you can see where the frag fork fit right into that zone right there. And then it was decided, you have to make a decision at this point when there's implant damage, iatrogenic implant damage. Should the implant be taken out and start over, regraft, or is it possible to effect a rescue? In this particular case, I decided to rescue it, and knowing the fact that this is a metric 4.1, and there are several implants out there, metric 4 millimeter diameter implants that carry a metric 2 millimeter screw. So I felt real comfortable rethreading this implant to metric 1.8. It just so happens that's possible because a metric 1/8 screw and a metric 1/6 screw carries the same thread pitch at 0.35. So it's a little bit of a challenge to go in and pull this off, but with the same guides that I used to take the screw out, was able to drill the pre-drill deeper by 1.3 millimeters as shown on this right side image, and then retap the implant to metric 1.8. And you can see now that I have about 3.5 brand new threads above the damage, and the threads that were damaged before now are cleaned up quite significantly. And we have an implant now that is re-restorable, and that's great. However, in this particular case, there was not a prosthetic option because there's no parts. So we had to create the parts to re-restore it. So before he was going to get a zirconia abutment, and that's really not possible at this point because the through bore on the abutment has to be just a little bit larger to accommodate the larger screw. So I went to a gold hue titanium abutment, and then of course there's the fact of procuring the screw. So since there is not one out there, we just made one. And so the screw is a 1.8 custom made for this situation, and it's the abutment's delivered to prescribed torque, and he's re-restored. So the question is then, when you see this whole case, what went wrong? Well, what went wrong initially was that the dentist didn't have any understanding of implant dimensions and the recovery tooling that he went into this implant with, and then obviously understanding this morning probably the excitement and the fear of failing complicated the situation as well. Secondly, he didn't have visualization, which is a critical key here. So going in there, understanding that you can do damage and you can create problems is huge. So with those issues pointed out, I think there are a few basic points here for success that I think you need to kind of have a grasp of before initiating some of these retrievals. First point is that I believe that all screw fragments are retrievable, at least initially, with maybe some very minor exceptions, one of which is if someone happens to resin bond a case together, they're very, very difficult to do anything with. But the normal mechanics, having a good understanding of the mechanics, staying out of trouble, not creating a worse problem, we've had extremely high success rate. I haven't missed getting a screw out for over 4 years. So, yeah, I think you can accept, you should accept a very high percentage of retrievals. The two questions then remain if you've taken one out, because a lot of times you may see one as specialists as someone's already tried to work on it. So the question is, what is left in the implant, as in Robert's case, to work with? You know, is there iatrogenic damage that you have to make that decision? Because question 2 is, how much effort is it going to take to actually save it, and is it worth saving? So on an individual case-by-case basis, you have to decide that, and are the skill sets available to actually render the save. When you look at a case the first time, and if you're lucky enough to see it the first time, then I think you have to realize that it's probably the easiest to remove right then. I don't mean as the first operator that it's easiest to remove, because every potential time you go in there to try to remove that, you potentially can complicate the retrieval, and it can happen very quickly because we're really dealing with small components. So dimensions are very, very small, and their tolerances are tight. So knowing that, visualization is super keen, really key in this process. And visualization, seeing is often said as seeing is believing, and I will say seeing is truly understanding. And if you can look at an implant situation long enough and understand what's going on in there before you attempt the retrieval, it is an amazing difference. The operating microscope I'm using is, normally I'm going in at about 16 power to take a look. I will bounce into 25 power, and they say that what you see is the square of the power, and it offers a huge advantage over just loop magnification. So prior to starting the recovery process, you also have to have a very, very good understanding of the operating theater you're working in, just like anything else. You have to understand the dimensions of the implant and the screws. You have to understand the actions of the recovery tools. You know, I had a 9th grade shop teacher that, you know, he had a bunch of boys in this shop, and he didn't want to lose fingers, and he had 2 things that he really often told people. One is you have to have respect for your tools, and 2, you have to know how a tool is going to hurt you. And in this situation, I would submit that if you have respect for the implant threads, have the respect for the implant interface, and if you know how a recovery tool can help you, but also how a recovery tool can hurt you, you can stay out of trouble. So how to evaluate the difficulty in this situation? I have a simple algorithm classification system that I use in my head, and I just wrote it down on paper because it's really what I transformed over time and how I was dealing with these cases. And it goes like this. There are 2 delineators on a diagnostic algorithm. One is the fragment position in the implant as it's relative to first thread, and the second is fragment mobility. Okay? So that means that there are only 4 options when there's a broken screw in an implant. So if you take a look at the cartoon on the left, you can see that the screw is above the top of the implant thread, and on the one on the right, the screw happens to be below the implant thread. So with the 4 potential situations, you can have mobility as a case type 1 for simplicity of discussion, and non-mobility if it's above. Well, these are the real nice. Mobile case 1 is a real nice scenario. It's a good day. Why? Because the fragment is above the implant threads. It's mobile. Almost any tooling that you have will help get it out for you. And the threads are protected from any damage as you're going in there. I don't get to see a lot of mobile ones because they are already taken out by specialists and everything. And I have to go down to the right as we go along. I'm going to talk about the 2s in just a minute because 2s and 4s, as we progress along, will really treat out the same way. Mobile 3 is when the thread is below the top of the implant, and that's just a little bit dicey, and I will explain that in just a moment. And then, of course, 4 is when you have a locked fragment that's not mobile, and it's below the implant thread, and it's the most difficult to retrieve. Why? Because there's the most potential for complication on the implant threads itself. Okay? So to really understand how one might relate to the other one, these are two fragments that I recovered. They're both metric 1/6 fragments, but they're really different in scope. The one on the left has a fracture through the screw body itself, and the threads aren't really involved. So consequently, the fracture zone with those sharp edges are not out in the threads, complicating removal. The screw fragment on the right side has been fractured through the threads itself, and there's a sharp corner on that top left side, and that's a potential problem. Because if that fragment rotates clockwise, you have to think about this just a little bit visually, but when that fragment, if it rotates clockwise down, that sharp edge is trailing as it's going down the threads. And it's the caboose on the train. And so that fragment will actually rotate down easily. But if you try to rotate that fragment up, that sharp edge at the top is leading. And so it will, because tolerances are tight, remember, that can actually bind in a thread and cause you to not have upward mobility on it. So a lot of times when you look at this one sharp edge on the right-hand side and you put it into an implant that's fractured and is below the thread, the top implant thread, a lot of times someone will think, well, it won't come up so there's automatic thread damage on the case. Well, maybe not true, because if you happen to be the first one into this case, I can tell you that it's probably that sharp edge. And so now you can see, if you happen to look into a case and you happen to have a case type 1, a mobile fragment that's sitting up high, and you happen to rotate it inadvertently down a little bit, checking it out, and you happen to rotate it down to the point where that sharp edge goes below first thread, all of a sudden it may not want to come up again. And so now you've taken a 1 into a 3, and then making the wrong moves on the case with the wrong removal tools, a 3 now becomes a 4, and the problem has compounded and made itself worse. So here's a second case today. It's Pam's case. This is a 3 to a 1, so you already understand this is going to have a nice outcome because this part rotated up. But if you look at the implant, you can see the screw fracture down in the body of the implant. The first line, the red line, is really the top of the threads on this implant. And the yellow line that I have on here now shows the top of the screw fragment. So we know we're a 3 or a 4 by the X-ray going in. Now if you take another clue from the case before we start here, you can see that this is the part that you came in with, and you can see the fracture was through the threads. And if you blow that up and take a real good look, before you even go into the case, you can see that that's a sharp fracture right through the threads. So that case is going to be a 3 or a 4, but we're going to have the potential for a sharp leading edge on that fragment. So we have the case that I showed, 3 or 4 depending on the mobility. But because this lady had never seen anybody before, I suspected it was a type 3. So we go into the case. Now here's an example of visualization. If you look at the case under loop magnification, I have the viewing angle here set, at least it was on my computer. I don't know how it is on the big screen, but it's about what you would see under maybe 2.5, 3.5 power loops. And you can see there's a screw fragment down there. Great. But it really doesn't help you assess things too much. Now this is the same picture blown up to about what you would see with about 16 power under the microscope. And you can see that this, now you can start delineating some screw threads and maybe possibly even the leading edge on the screw. But look at what happens when you bump into 25 power. This is the same picture again, just blown up to the angle of view of about 25 power. And now all of a sudden you can see screw threads down all along down here, so we know it's below the top of the screw threads. And then here's the leading edge of the screw fragment. Okay. Now with some, you'll know it's a great case because here's the screw in one piece, and you can see what that fragment looked like. You can see that sharp leading edge that's pointing out at us, and you can also see the original roughly 25 power image of that. Remember, the images taken under the scope are coming off a mirror so that they're actually reverse. So when you're trying to back a screw out, it looks like you're screwing it down, but actually it's coming up because it's a reverse image off the mirror. So here's an endodontic explorer. That's all I'm using at this point to try to recover this screw. Very simple. There's another little trick that's oil of wintergreen. A mechanical engineer in San Diego told me about this several years ago. It's a very lightweight organic lubricant, and it helps kind of break up some of the possible biofilms and things that might be in there and just decrease the friction rate going out. But it took about 20 minutes maybe to take this screw from where it was initially at about 10 o'clock over here to 3 o'clock, and it's going, and so I'm moving it up. And then you see the next image that we've taken along this extraction, and the screw is actually up out at us, and it looks like it's gone up just a little bit, but in fact I'm up 390 degrees from that last image. I've gone around once all the way up, and at this point the screw became easy to take out. So the next image, I'm up here almost at 12 o'clock, and it just came quickly up to that point. And why was that? Because that leading sharp edge now exited the implant threads, and now we've taken it from a 3 to a 1, and it's easy. So this case was totally retrieved without any other instruments other than an endodontic explorer and a little bit of oil wintergreen. And that's just having the visualization to know what's going on. Okay, so this was on the left-hand side. You will see the fragment, and on the right-hand side you'll see the empty implant, and it's pristine. It's ready to go again. Okay, so we've talked about 1s and 3s, the potential for 3s going into more trouble with inappropriate instrumentation. What about the 2s and the 4s? These are the ones that are locked for one reason or another. 2s, I think, I've seen scenarios where they broke on insertion. Maybe the end of the screw hits some obstruction in the implant. It stops rotating. The head of the screw keeps rotating as it's torqued into place. The whole screw body takes the load, or it's over-torqued, and the screw fractures. But it leaves a fragment that's tight in the threads. On the one that's down below, the 4s, it's hard to know exactly why all these might get tight, but some of them are locked, and in my practice where someone's tried to work on them, a very common way that a screw fragment gets locked is someone goes in with an ultrasonic instrument, tries to take it out with an ultrasonic instrument, and that shot peens the top of the screw to the threads and essentially distorts the anatomy in the implant enough that it locks the screw in place. So what do you do for tooling on types 2 and 4, and how do you control that? Well, if you start looking at the tooling out there, you have a particular brand that's fractured or a screw that's fractured, and you start asking reps and things, you're going to find that I haven't personally found anything that I wanted to use that had enough precision, because some of my goals are a little different than some of the tooling that you might find out there. You need to implement a technique to increase your removal torque. That's obvious. The screw's stuck. You have to get more torque on it. But how do you do that? How do you implement that torque? Some people try to cut slots. I actually drill little holes in it, and I'll show you in a moment. But the idea here is to use the least destructive technique possible. I don't want to go in there blasting the whole screw out when I don't need to, and I haven't had to take a screw out in pieces in several years. And then work concentrically. That's another thing. Stay in the center of that screw. Why? Because you're staying away from the threads, you're staying away from the interface. Excellent idea. Avoids complications. And the tooling must have precision tolerances because we're dealing with small spaces and we're dealing with small, tight tolerances. So our tools have to match those criteria. Okay? Try to find it out there. It's rather difficult. This happens to be an implant. It was a case that I looked at the manufacturers, what they had for this particular implant, They had a guide, they had a recovery tool, and they had a handle for it, and they charged about $500 for it. And so I looked at it. The rep dropped one off for me to take a look at it. I looked under the microscope, and the guide against the recovery tool, their particular version of a fragment fork, had so much wobble in it that I could touch the threads on this opened up analog if I got it down into the implant. So I just totally rejected their option, and I made my own guide, and happened to have a little machine shop. So made the guide, and this is a drill. This is a $4 drill that I modified. But when you assemble it all, you have a screw that's very, very precision into the internal aspects of the implant. And this is the kind of control you need to be able to effectively work that. This is a blow-up of the guide and the drill. This happens to be a 31 thousandths drill. And that drill is capable of going down through the center body of the screw if used correctly, right through the middle. It's a robin-hooded screw, if you use archery terms, right in the middle of the target. And was able to pull that screw fragment out without problem. Now, normally, I don't have to drill that deep, and here's the technique. I initiate the drill into the screw fragment. Remember, this is a very locked fragment. It won't come out with just routine issues. So I go down about a half a millimeter, about 20 thousandths of an inch, and then utilizing by hand this fragment fork. It's a 1 millimeter fragment fork, which is 39 thousandths of an inch. But that leaves 8 thousandths sidewall, and so by the time you put the fragment fork into this hole, it wedges itself into that hole, and then with a reverse counterclockwise lefty-loosey turn, it will affect removal torque. But it's guided because the center hole on that fragment is guiding the fragment fork in there, and you're staying away from the threads. Okay. Now, this happened to be an old, I think the case was a 3.3 external hex IMZ implant that had been in for over 20 years in number 8 position, and he had a different implant in the 9 position. The 2 crowns were splinted. He was very happy with the restorative work on there, but one of the screws had come loose, and the other one, he didn't roll it, and the other one had fractured. This was a retired machinist. So basically, I pulled out the fractured component like this, and then I was able to make him 2 new screws, because try to find screws for a case that's 25 years old. IMZ's out of business, and the other one was happened to be a 3i case, and I could get a screw for it if I waited 3 months and for about $180. So I just made 2 screws. So we solved the case. Now you'll notice that the screw hole in this implant, or this screw fragment, is not quite concentric, and it's probably had a little trouble getting the guide really centered on there. It turned out to be not an issue here because I'm still in the body of the screw and I'm not anywhere near the threads on the implant, so it was fine. That can become a problem if you can't, if the screw is so locked in there you can't get it out. You must be concentric, because if you have to take this screw out in pieces, you must be concentric, because you have to take the whole body of the screw out before you can go after any of the residual threads. You should not introduce a tap into an implant if there's part of the screw body in there, because taps are brittle and taps break. And if you try to introduce a tap with too much interference in there, it can cause you major grief. So I try to stay concentric all the way. By staying concentric, you're taking the screw body out. You're not risking any threads, even in a total removal. Haven't had to do it for several years because of this technique, however. Okay, I want to show you one of the case that came actually out of Canada. This was out of Montreal. This was a case that a prosthodontist in Montreal sent to me to take a look at to see what could be done. It's fractured, and this is just they've already gotten the screw out, but here's the impression I had her send me, and I photographed it every 90 degrees. And you can see what a fragment fork can do introduced into an implant, just like in Robert's case, but this one's worse. And it's very, very significant damage to this implant. I don't know what happened. I have a feeling the implant was explanted. Could it have been recovered? Possibly with enough effort, but that's a decision you have to make at that point in time. Okay, just to summarize what you have to do, I said that you have to be able to evaluate the tooling that's out there in the event of getting better tooling, but you have to, on the stuck cases, 2 and 4s, you have to imply more removal torque. So you definitely have to have the least destructive possible. You also have to work concentrically away from the threads. So any tooling that allows you to do that is a winner. And you have to have precise tolerances, precision tolerances, because dimensions are small and tolerances are tight. And get under a surgical microscope, either borrow or buy one. For 2 years, I was under an endodontist scope across the street from my office. That's a great place to find them. If this was an endodontic meeting, everybody's head would be going yes. Everybody in the endodontic community uses them now, especially in our area. And with all that, I would thank you for your kind attention today.